Hello, and welcome to Part 2 of this 3-part training course on colorectal cancer screening. In Part 1 of this training course, we explored the current burden of colorectal cancer in Idaho and the barriers as well as motivating messages to support colorectal cancer screening. In Part 2, we will cover screening options, including at-home stool tests and colonoscopy. We will discuss the advantages and disadvantages of each option. The U.S. Preventive Services Task Force recommends that both males and females at average risk complete colorectal cancer screening starting at age 50 and continuing until age 75. Individuals with a family history of colorectal cancer may be screened prior to age 50. The risks and benefits of different screening methods vary, but the best test is the test that gets done. There are 2 common methods for colorectal cancer screening: at-home stool testing and colonoscopy. The first type of stool test is the Guaiac-based Fecal Occult Blood Test, or FOBT. Guaiac-based tests are the most common type of stool test used in the United States. Guaiac FOBTs require stool samples to be collected on 3 different days. Each stool specimen is collected by using a collection stick to take samples from 2 different areas of stool from each bowel movement. The stool should be collected on the paper provided before it comes into contact with the toilet water. The kit is then manually processed in the clinic or lab. Standard Guaiac tests should not be used. Older forms like Hemocult 2 are not recommended. Newer versions like Hemocult Sensa have better sensitivity. If your clinic uses Guaiac tests, be sure the sensitivity for cancer is greater than 50%. Also, note that Guaiac FOBT test results are influenced by foods and medication. Samples should be collected 7 days after dietary and medication restrictions. If this creates a barrier for patients, FIT testing may be a better option. The second type of stool test is the Fecal immunochemical test, or FIT. FITs are easier to use and more likely to be completed by patients than Guaiac tests. FITs specifically test for human blood and for lower GI bleeding and have higher sensitivity than older forms of Guaiac-based FOBT. Because FITs test specifically for human blood, there is no need for dietary or medication restriction. Most FITs require samples from only 1 or 2 consecutive bowel movements. Just as was discussed about Guaiac FOBTs, not all FITs are the same, nor have they all been tested rigorously. Be sure your clinic is using a FIT that has been evaluated in clinical practice and for which data on performance in the peer-reviewed literature show at least 50% sensitivity for cancer. Both the high-sensitivity Guaiac FOBT and FIT can be used to detect colorectal cancer. Important items to note about stool testing for both Guaiac FOBT and FITs are: a high-quality stool-based testing program requires that the high-sensitivity Guaiac FOBT or FIT is completed annually. Secondly, there is no evidence that any type of stool blood testing is sufficiently sensitive when used on a stool sample collected during a rectal exam. Finally, if a stool test is positive, a follow-up colonoscopy is needed. It is important to refer all patients with an abnormal stool blood test for colonoscopy because this may indicate the presence of a significant polyp or cancer. Do not repeat an abnormal FOBT or FIT. Abnormal FOBT or FIT should not be followed with other less definitive tests such as flexible sigmoidoscopy, barium enema, or CT colonography. The 2 main differences between Guaiac FOBT and FITs are around the need for dietary restriction and the cost of the test. Guaiac FOBT requires dietary restrictions for 7 days, while the FIT does not. FITs are more expensive than Guaiac FOBTs. However, FITs are usually reimbursed at a higher rate than Guaiac FOBTs. Overall, there are distinct advantages to using stool tests. On a one-time basis, they are a less expensive option than the traditional colonoscopy. They do not require bowel preparation and can be done in the privacy of the patient's own home. Because they can be completed at home, there is no need to take time off of work, nor require assistance getting home after a procedure. Stool testing is non-invasive and therefore poses minimal risk to the patient. Finally, stool testing limits the need for colonoscopies, as a colonoscopy is required only if a stool blood test result is abnormal.
I absolutely recommend take-home testing for colorectal cancer screening for my patients. It allows them an opportunity to perform a test in the comforts of their own home with relatively limited instruction that they can do at a low cost to receive a screening that could potentially save their lives.
Colonoscopy is the most common colorectal cancer screening test in the U.S., accounting for about 85% of screenings. Therefore, your patients are probably more familiar with the colonoscopy than at-home stool blood tests. The main advantage of screening with colonoscopy is that it is a screening, diagnostic, and therapeutic procedure. It allows for direct visualization of the entire colon lumen. If screening results are normal, then screening can be conducted at 10-year intervals. However, it is important to remember that colonoscopy is not perfect. Colonoscopy misses about 10% of significant lesions in expert settings, and there is a wide variation in quality. Colonoscopy is more costly on a one-time basis than stool testing. In addition, there is a higher potential for patient injury than other tests, and there are greater patient requirements for successful completion, like adequate bowel prep and pre-procedure office visits. Access may be limited by insurance status or local resources. Finally, many individuals do not want an invasive test or a test that requires bowel prep. Both stool-based testing and colonoscopy have advantages and disadvantages. Let's walk through a brief review. Stool testing is less expensive, does not require bowel prep, although Guaiac-based tests do require dietary restrictions, can be completed at home, and is non-invasive. Colonoscopy advantages include longer intervals between screening, and the fact that it is not only a screening, but it is diagnostic and therapeutic as well. Stool-based testing and colonoscopy have shown similar decreases in mortality, so there is no right or wrong test. The goal of this training is to provide you with the information necessary to offer and recommend screening options appropriate for each patient's medical and personal needs to ultimately reduce the burden of colorectal cancer in Idaho.
I recommend the screening test to my patients, the one that they'll be able to get done. If they're going to be able to obtain a colonoscopy and have a goal to get that done, I'll recommend a colonoscopy. If it's not financially feasible for them to do that, then I recommend the FIT test. The best test for any patient is going to be the one that gets completed.
Idaho's screening rate is one of the lowest in the country, but success is on the horizon. States who have successfully increased screening rates use a higher proportion of stool testing than currently used in Idaho. Each bar shows screening rates for 15 different states. The different colors of the bar indicate different screening modalities. Blue is colonoscopy, red is sigmoidoscopy, and green is stool blood testing. Idaho, California, and Hawaii are highlighted in yellow for comparison. All three states have similar colonoscopy screening rates. However, both Hawaii and California have higher overall screening rates. These two states accomplished that with a higher stool testing rate than Idaho, about 20% versus Idaho's 6%.
At the clinic that I work at, we've definitely seen an increase of our colorectal cancer screening rates, largely due to the take-home FIT test that's been offered through our clinic and our focus. The goal of medical care is to offer preventative care in an affordable, effective manner, and I think we've done that with the take-home tests.
The two main screening options discussed today give your patients options to ensure completion of screening. At the end of the day, the best test is the test that gets done. Your recommendation is the most powerful factor that determines whether an individual gets screened. If we can screen 80% of Idahoans aged 50 to 75, then we can prevent thousands of new cases of colorectal cancer. Thank you for joining us for Part 2 of the colorectal cancer screening course. Join us for Part 3 for additional information on what clinics and healthcare teams can do to improve screening rates.